You are welcome to my channel. Today I'll be talking about secondary survey in trauma cases involving children. In other words, pediatric trauma secondary survey. After resuscitation and stability, then we want to know exactly what is responsible for the presentation. Then secondary survey begins. We'll have to start inspection from head down to the toe. At the head region, we want to see the fontanelle if it's bulging, any swelling or bruises, abnormal shape or bleeding. After the head, we'll move to the eyes. While trying to inspect the eyes, we'll give instruction to remove the eyeglasses if the person is wearing one, remove the contact lenses. Then we'll check for raccoon eyes or periorbital ecchymosis, check for conjunctival hemorrhage, ocular entrapment, visual acuity with glasses on, and pupillary size. We'll go to the ear region and inspect for vital signs, that is retroocular ecchymosis. We'll check for hemotympanum, bleeding, perforation, or CSF otorrhea. We'll get down to the mid-face and we'll be checking for nasal swelling, nasal deformity, any bleeding, any rhinorrhea or CSF rhinorrhea. The oral region will be checked for oral trauma, malocclusion, intraoral lacerations, and will palpate maxilla for Lefort fracture. We'll check the cervical spine and the neck, but we'll first of all immobilize the neck with collar. Then we'll open the collar and palpate the trachea for heading deviation. We'll check for neck veins distension and tenderness. Still at the cervical region of the neck, we'll check for subcutaneous emphysema, laryngeal fracture with crepitus, carotid artery bruit, and penetrating injury. The chest region will be inspected for obvious deformity, chest movement with respiration, respiratory distress, and cyanosis. And then we'll palpate for the clavicle, the ribs, the sternum, crepitus, or tenderness. Still at the chest region, we'll have percussion of the chest, checking for dullness, and also we'll have tactile parameters done. At this juncture, we can then auscultate for breath sounds and heart sounds. We'll go straight to the abdomen, inspecting for bruises and seatbelt signs, dissension, and masses. And we'll go straight after inspection to auscultation. We'll auscultate for bowel sound and breath. After the abdominal auscultation, we will go straight to have abdominal percussion. And then we'll be doing that to detect organomegaly or fluid presence. And then to palpation, light and deep, eliciting tenderness, rigidity, or gagging, signs of peritonitis. And we'll check for vaginal bleeding at the perineum, rectal bleeding, contusions, lacerations, or hematomas. Will be done with the perineum when we lie the patient prone so that we can have rectal examination done, checking for bleeding, sphincter tone, prostatic anomaly, and blood-stained gland. The extremities will not be left out. We'll inspect for fractures, foreign body, dislocations, and the patient can walk around and tell him or her to walk, and then we'll check for gait anomalies. Then we check for axillary region as well. Still on extremities, we're going to palpate for pulses, crepitus, Marcus tendinus, and pelvis with heel of the hand on iliac spines. At the back, we will log roll, and then we inspect for any obvious deformity and palpate for tenderness. Neurological examination will involve full neuro examination, consciousness and pinpoint pupil, sensory motor power reflexes, and cranial nerves. And finally, we put all our reports together in concise form. The findings that will help with appropriate interventions must not be excluded. And with that, I've come to the end of this short presentation as per secondary survey in pediatric patients involved in trauma. Thanks for listening. Remember to share this. Remember to subscribe to my channel so that you can get all my presentations immediately they are published. I appreciate it.